McAllister Castellaws. I am joined by my colleagues, Dr. Jana Lavid. I always say your last name wrong. I'm so sorry.
It's all good. Laverdier. Dr.
Lavidier,
Laverdier.
thank
Yeah.
you. And Carrie Reed from Carrie is from Crossover Healthcare Ministries, and Dr. L is from Johnson Health Center. As we are going through our presentation, we'll go through slides first, but I will encourage everyone to please put questions in the chat as we are going through. I know some of you did send some questions in as you registered, so we do have those, and we'll answer those at the end. But as we're presenting, if you have questions as we're going through, drop them in the chat and we'll address them at the end as well. But with that, I will go ahead and get started. If at any point something happens and you lose track of the slides or my screen stops sharing, please just let me know. Bear with me. I'm on two separate screens, so I might not be able to see you all. So just come off mute and flag me down. All right. We'll go ahead and I'll get started. So thank you all for joining us. Over this next hour, I'll be spending some time talking about lessons in ICD-10 code adoption for the oral health integration in our dental safety net. So here we all are. I am a general dentist. I've had the pleasure of getting to work with Virginia Health Catalyst as a clinical consultant for the past several years. I originally started my clinical practice in Virginia in an FQHC in Norfolk area, and I've worked in several other FQHCs throughout my practice as well. I now live in Madison, Wisconsin, but still get a chance to come back to Virginia every once in a while and visit my colleagues there. Dr. L is the Chief Dental Officer at Johnson Health Center, and Carrie serves as the Dental Program Manager at Crossover Healthcare Ministry. So Crossover located in Richmond area, and Johnson over in Lynchburg as well, to kind of give you an idea of geography. I do want to take a moment to thank our funders. This work has been funded through financial support from the CareQuest Institute for Oral Health. So we greatly appreciate their financial support. Without them, this work would not be possible. So thank you, CareQuest, for continuing to financially support this important work as well. So I'm going to take a moment just to start by grounding us as to why ICD-10 integration is important and why it matters in the dental setting. And then we'll spend some time as we share implementation strategies, some of the real world challenges and practical solutions that have emerged from this pilot program. And then we'll end by discussing some sustainability and replication insights that we have gained through this project that we hope that you can bring back to your own clinics, your health centers, and some of your state level work as well. For those of you who are not familiar with Virginia Health Catalyst, Catalyst is committed to ensuring that all Virginians have access to comprehensive health care, including oral health. The mission of this nonprofit is to eliminate barriers to optimal health by addressing inequities and inefficiencies within our healthcare system. Catalyst aims to transform and strengthen the health system and its environment by collaborating with community partners, addressing health disparities, and advocating for policies that benefit the most vulnerable populations. The goal is to create more equitable healthcare systems. Catalyst achieves health equity through a multifaceted approach. This includes public health by addressing community, environmental, and social factors that equitably improve oral and overall health. Policy work that advocates for laws, policies, and regulations at all levels of the government that support positive health outcomes and health equity. Public awareness. Catalyst does guide decision making with research data and information that has the critical role of oral health and overall health. Clinical and community care. Catalyst strives to ensure that care is equitable, high quality, coordinated, and integrated. At Catalyst, we believe that education, advocacy, and technical support are essential for influencing policy and driving systemic change. By fostering open communication and building strong partnerships, such as the work in this pilot, we are able to strive for excellence and respect the voices of our community. We're able to place equity at the forefront of our healthcare landscape. And then through this unwavering commitment, we're able to transform the healthcare in Virginia to be more inclusive and accessible and ensure that everyone in the state has opportunity to thrive. So why ICD-10 codes? This is kind of the first question that a lot of people ask when I start talking about this pilot, and I think Dr. Ellen Carey had for us when we approached them about participating in this pilot. Why ICD-10 codes in particular? What are they? Why do we even care about them? What do we actually want to do about this? Why is this work so important for our dental safety net? Well, sorry, I skipped ahead too a little too fast. Dentistry as a whole has historically been really procedure focused. For those of you who are in the dental community, you know that we utilize CDT procedure codes. Those procedure codes are going to tell us what happened during our appointments, but not why. And that why is really critical to understanding and being able to create a much more integrated and value-based care system. ICD-10 codes are those diagnostic codes that our medical colleagues use, and they bring that clarity, that why to why that procedure happened. It can align our dental documentation with a medical model that supports chronic disease tracking. Really importantly, these codes bridge dental, medical, and even social health and create a more universal clinical language that improves communication, referrals, and care plans for our patients. So like I said, dental documentation is largely procedure driven. Um, in a value-based care system, a reimbursement method is going to tie payment to clinicians based on their quality of care delivered in regard to the effectiveness and efficiency, not just the number of procedures that they are performing. And one way to measure the effectiveness and efficiency of care delivered is being able to utilize things like diagnostic codes. Diagnostic codes help provide insight regarding risk adjustment for patient populations, track changes in chronic conditions over time, provide insight into resource allocation for specific patients, such as why some patients may require more resources or more treatments than others, and can provide insights regarding the appropriateness of the type of treatment that was performed. Traditional reimbursement models follow a fee-for-service pattern where a clinician is paid based on the service performed. And I think all of us appreciate that is what happens in dentistry. There's no requirement to demonstrate improved health outcomes, cost savings for the clinic, or a positive care experience for the patient. A value-based care system requires tracking and reporting of these measures. We're looking for improved health outcomes, looking for cost savings, and provide a much more comprehensive, complete insight regarding community health status and opportunities for improvement in health. So there is this shift in terms of moving from a opportunity to look at moving away from doing the procedures, but into how are these procedures affecting the health of the community, and not just the health of just your individual patient, but the health of your community as a whole and the impact that you are having on your community by the dental work that you are doing. Um, we know that many dental conditions are considered chronic diseases. That's one thing that I like to lead with. Dental disease is a chronic condition. Dental caries is a chronic condition. Periodontal disease is a chronic condition. And this is something where ICD-10 codes can be really helpful in helping support and demonstrate this. This is how we're able to capture these diagnoses and be able to track these conditions and how they are changing over time with our patient populations. Um, we know that a patient, once they have been diagnosed with periodontal disease, that they continue to have periodontal disease. The goal is to get them into a stable state. I myself am someone who does have periodontal disease. I'm just now in a place of stabilized periodontal disease. I'm on a 3-month recall, but it took me a while to get to that point. So it's not something that was, I'm not cured of my disease. I'm now in a maintenance phase. And that's true for a lot of our dental conditions as well. Another unique aspect or newer aspect that was introduced to the ICD-10 diagnostic coding system are these everyday influences, these social conditions that also influence our health, our social determinants of health. And these are actually captured through Z codes in our ICD-10 codes. And these are things like housing, transportation, food security, factors that can often drive oral health outcomes. much more so than procedures will. Um, and utilizing ICD-10 codes within our our not just our dental procedures, but within a broader electronic health record system, gives a chance to create a shared care plan across medical, dental, and uh, behavioral health, social health care teams, be able to reduce duplicative efforts and help improve continuity when patients move across providers or systems as well. Um, Again, these ICD-10 codes are an opportunity for standardized language, not only within the EHR, but across interprofessional teams. Granted, it is a language that we will all have to learn to speak together. Our medical colleagues are the most fluent in it, but it does not mean that we cannot learn it together, but there's an opportunity for shared language amongst all of us here. And that is where we kind of grounded ourselves in the work of this pilot program. So that's what kind of led us to the goal of the pilot itself, was we saw this opportunity of there's a shared language here, so what could we do with it and how could this help create a much more integrated healthcare system within the safety net in Virginia. So uh, over the past 24 months, there were two dental safety net clinic teams identified in Virginia, Johnson Health Center and Crossover Healthcare Ministries, that worked along Catalyst to help operationalize best practices, evaluate success, and create a replicable model for Virginia's safety net clinics and how to adopt and implement ICD-10 codes within their dental clinical settings and more broadly in a within their EHRs and across their whole healthcare system within their whole healthcare system within their community clinic, I should say, not the entire healthcare system of Virginia, but within their healthcare system of their clinic. Throughout this time in the project, our participating clinics receive technical assistance, education, and any necessary resources to effectively design and implement clinic-specific programs that met the needs of their patients and the families that they serve. They had the opportunity to exchange ideas with one another, working towards their same goals. The funding that they received ultimately aimed to help push Virginia towards a more equitable, person-centered, and value-based oral health care system. So the goal of this project, like I said, was ultimately to see how we could use these codes to contribute to a more integrated, interoperable healthcare system within these community clinics and what facilitators and barriers do exist in having that achieved at this local level, in the sense of the local level within a community clinic, and what would be needed for sustainability and for replication moving forward. So, as I said, as we were thinking about with the ICD-10 project, again, a lot of this involved taking what is kind of absent in dental, which is understanding why dental procedures are getting performed, and being able to start to bring in a better understanding of why dental procedures are being performed or why dental referrals are happening, and starting to be able to better capture in a more uniform way trends of care that is happening, whether it is referrals or procedures that are being performed, and then looking to see how these codes, the utilization of ICD-10 codes, could contribute to a much more integrated system, especially with individuals with chronic disease who need care across a multidisciplinary team, and then be able to kind of push and look towards how this might affect a value-based care system within Virginia, looking towards the future, understanding that is not something that would happen overnight necessarily. So again, there are a lot of different parts that come into play when we think about how ICD-10 codes kind of fit in together with all of this. And that is with the ICD-10 codes down here at the bottom, really understanding, giving us the why to the procedure. So the why as to our dental procedures and to our medical procedures, but understanding that there is a lot of other components that come into play here. that there are individuals from our medical team that are involved, our oral health team. There are elements of billing and data that have to come into play. Our community health workers and our connectors who are so integral into navigating those Z codes, those social determinants of health, those other diagnoses that are getting captured with our ICD-10 codes that are not necessarily chronic health conditions, but are chronic social conditions that are also affecting health outcomes, and how all these things kind of come together to all affect the health of an individual, but also the health of the healthcare system in and of itself. Um, so those are kind of how all these pieces come together within the pilot program here. So with the pilot program, we really took, what I want to emphasize is we took a phased approach to the implementation and really following this iterative and refinement approach with a focus on sustainability from the start. We do recognize that the ICD-10 work touches every part of the workflow, from clinical decision-making to scheduling, to triage, to care coordination, to billing, and to reporting. So throughout this process, we began way back when at the start of this project with the readiness assessment with our clinics to kind of first lay that foundational knowledge and see where everyone's understanding was, and using that readiness assessment information to be able to build some education and training modules for our clinics. And from there, being able to then start helping them build their target, their pilots actually, and help them identify patient populations that they'd like to target, and being really intentional about what codes they would like to adopt and trial. So not adopting every single ICD-10 code at once, every single dental diagnoses, not every single Z code at once, being really intentional about what codes or how we wanted to approach adopting the ICD-10 codes into their workflows and which patient populations there. And then moving into implementation and being very conscientious around how that was going to work in their clinics, and then being able to look at that workflow, practice that workflow, and continue to refine that workflow. And then going through that continuation process, and then as like I said, refining and adjusting as needed, and completing this kind of through a phase one, and then going back and doing a phase two with this pilot as well, and being able to expand and build on that. One thing that we did learn through this whole process, and we had identified at the start and kind of confirmed throughout this, is that a successful implementation of this project requires a multidisciplinary team. And this is beyond your clinical team being multidisciplinary. This work extends far beyond your dental team. It requires the work from your IT, your quality team, community health workers or care coordinators, your medical leadership, and administrators all play really critical roles in this work. Cross-department buy-in is really essential, and that coding really only sticks when people see their roles and capturing, updating, and using this data. So this is a really collaborative effort across all aspects of your health center. Like I said, we did start with that readiness assessment. Just kind of want to highlight that when we did that readiness assessment too, remembering that since this was a multidisciplinary team, the readiness assessment also was given not just to our clinicians, but to administrators as well. And we looked at it for both individual team members as well as the clinics as the whole. And we want to understand everyone's kind of baseline of where they understood what ICD-10 diagnosis codes were, what their understanding of value-based care was, what their knowledge of their current electronic health record was, and then being able to utilize this to identify any technical gaps that they had, and inform how we wanted to guide and develop the educational modules and the technical assistance, and identifying too that the two clinics did not necessarily move at the same speed, and that was expected, and that was totally fine. And that actually, I think, helped with some of the processes as well, because as they kind of moved at different paces, there's opportunities to learn from one another as they moved through those different spots or different paces as well, especially as not only did they choose different target populations, but as they moved that way, there was lessons learned at different times through that. And with that, I'm just going to take a moment to pause, and I'm going to let Johnson and Crossover share a little bit about their own experiences with participating in this pilot program. So I'm going to go just to this next slide and pause for a moment, and I'll let Dr. L and Carrie, I don't know which one of you would like to go first, but
Sure,
whomever.
I'll go first if that's okay,
Okay.
Carrie. So I'm Dr. Laverdier. I'm Chief Dental Officer at Johnson Health Center. And I remember back in 2023 when Catalyst had approached me about this project. Truthfully, I did not know much about ICD-10 codes or SDOH codes. I had heard of the acronyms in the past, and I'd sometimes pay attention a little bit to billing, seeing attaching some type of generic ICD-10 code, but I knew I didn't really have to pay too much attention to it, with the emphasis more on the correct CDT code. And so when Catalyst approached me, I was kind of thinking of different ideas, and one particular conversation I had with a nurse practitioner at an all staff meeting at Johnson Health Center kind of came to mind. And I remember sitting down at this table. We had never met each other before. I said, "Hi, I'm Dr. Laverdier." The nurse practitioner said, "Hi, I'm Jean." And immediately she went into, "So why are you sending blood pressure patients over to me?" And I found that conversation really interesting because I think it just kind of brought to light that sometimes we don't always communicate with each other very well on why we may need certain things. A nurse practitioner, for example, may not understand why I'm sending a pressure patient over when a lot of the times it might be dental anxiety. So I wanted to center this project and create something different. um, Working with her, identifying her as our medical champion at the time. It always really helps when you're working with these pilot projects to find individuals who are motivated, especially if they're motivated in oral health, which this awesome nurse practitioner was. Unfortunately, and we'll go into more barriers later, she did end up leaving Johnson Health Center 5 months in. And so we'll talk about some of the challenges to sustainability and what that looks like with I think turnover was a big thing for us. But to go back to our workflow, kind of what we did at Johnson Health Center was look at a patient when they come into the dental clinic, whether or not that's for emergency care or something as simple as restorative or extractions. Patient sits down in the operatory, our dental assistant um, completes the medical workup, reviews vitals. If the vitals are higher than our clinic policy. So at Johnson Health Center, we try to obtain 3 blood pressure readings in 5-minute intervals. Whether or not it's an emergency or non-emergency, our emergency cutoff is 180 over 110. So if blood pressure remained high, above the 3 readings, the dentist would then come in and make a decision of creating an internal referral to medical. And with that internal referral, we would attach an ICD-10 code. We would take a look if the patient was of, medical record at Johnson Health Center. And we would base the ICD-10 code based off of that. So if the patient had been diagnosed with hypertension in the past with a provider, in that internal referral, we would include the I-10 code, which is hypertension. If the patient was not of record and was a new patient to dental, we would send a medical internal referral to medical with the ICD-10 code R03, which is elevated blood pressure without diagnosis. This would go to our referral coordinator, who would then set up an appointment with medical to be reviewed, and then medical would send an internal referral back to us in dental, and we would schedule and review the notes, and hopefully everything would move smoothly from there. The goal was to also try to cut down on delays and improve communication with our medical teams. So that way we could transition the patient and try to prevent as less steps as possible. There's still a lot of work to be done with this pilot, and we have run into some major barriers. Again, I think workforce was a big thing. We had lost our medical champion, our dental champion at 1.2. We had some turnover with our community health workers as well, and a lot of internal restructuring, I think, over the last couple of years, which has significantly delayed, because when you have turnover, it's hard to find an individual that will prioritize this. Because not everybody has a passion for oral health too. And I think that's what makes us successful is finding people who are really willing to push this forward. It's not easy work by any means because it's a lot of brainstorming, a lot of development, and you really need to have that passion. But there were a lot of lessons learned, and I'm curious to see where this moves forward in the future. But that was Johnson Health Center.
Thanks, Dr. L. Here, I'll turn it over to you.
Oh, sorry, I couldn't find my mic button there for a
You're
moment.
good.
Hello, everybody. So, for crossover, when we were first approached by the Catalyst, we were like Johnson, we had not really in dental used ICD-10 dental codes before. So we had to do a little research and kind of figure out what we could do, what kind of project or aim that we could develop that would include both a medical team and a dental team. So after roundtable discussions, we determined our focus would be on diabetic patients because here at Crossover, like many other clinics, probably our most chronic disease condition that exists among our patient base is diabetes. So our focus became on diabetic patients. And to drill it down a little bit, because we have such a large diabetic patient population, we decided to focus on uncontrolled diabetes. So our goal was not for the primary care providers to diagnose the level of periodontal disease in their patients, but just to recognize the signs of periodontal conditions and have that conversation with their patient during their medical visit. So we developed workflows for both medical and dental teams. And while the workflows were very different, both workflows flowed into an integrated process for that patient's care coordination and care plan. So for phase one, our project, like Johnson's, were two-phase projects, and our aim, we scaled down to follow just 11 patients who shared the same identifiers, and those identifiers were patients with A1Cs over 9 who have not recorded a dental visit in the previous 2 years, whether they were crossover patients or outside of crossover. They had not visited a dental office in 2 years. So these patients also exhibited good compliance history, which made them really good for this project. So it would make it easier to follow if they were attending their follow-up primary care visits. So we selected these 11 patients. So our primary care providers on their end would implement an oral health discussion and do a visual exam, oral health exam at the primary care visit. To make to help enhance the primary care clinicians, we teamed up with the Catalyst and we developed a comprehensive, not a very long, but a comprehensive online periodontal training. So our primary care providers were staff providers and they were eager to participate in this. And they attended this training and familiarized themselves with different stages of periodontal disease and how the oral tissues would most likely present during a brief oral exam during the primary care visit. Once the visit was completed, the providers sent a message through our electronic health record to a designated dental staff member to schedule hygiene visits and a comprehensive periodontal exam with our staff dentist. It was at that visit that the staff dentist would identify the appropriate ICD-10 dental code, and the dental clinician would then add it to the patient's problem history list in the patient's hub of the co-shared chart. The dental ICD-10 codes were now included in the patient's problem history moving forward. So we're excited that the dental ICD-10 codes now exist alongside all of the other diagnosis codes that the primary cares have added throughout their history with their medical visits. The recare appointments were subsequently scheduled, and these patients were followed for several months. The challenges for us was losing some of the patients over phase 1 as they became lost to care for both medical and dental. However, a great result was the project yielded 2 patients who were provided partial dentures, which greatly improved their mastication function, which is very important for their nutritional care plan. So we were really excited that we were able to follow these patients, and we enhanced their ability to manage their diabetes through their nutritional care plan, as well as, identify their periodontal disease stages and follow them with routine dental care. One thing that was also a very good result is these patients were very compliant with returning for their dental appointments and follow-up visits. So I think that with the primary care clinicians having that initial oral health conversation, they were able to convey to the patient the importance and the role that oral health does play in the management of their chronic disease. So we considered that a really good outcome. For phase 2, we shifted to a much broader plan, and our high-risk demographic became the pediatric patients, because at Crossover, we do see a lot of pediatric patients who are higher risk due to undiagnosed medical conditions, lack or barrier to dental care in the past. So at this stage of the project, we flipped the responsibility for the ICD-10 dental coding documentation back to our pediatric primary care providers. Our providers in this phase were not just the staff providers, but they also included the volunteer clinicians as well. So the pediatric providers were first given an overview of the project by our assistant medical director. Then we also gave the providers a detailed process and workflow map and ICD-10 dental code cheat sheet. This cheat sheet also was posted in all the PC exam rooms. The cheat sheet is a condensed version of the most frequently used ICD-10 dental codes with their descriptions. This saved the providers a lot of time. They could quickly reference the applicable code without wasting time searching the ICD-10 database in the computer. For some children, providers generated an internal in-house referral via the electronic health record to our dental staff based on the urgency of the assessment code that they documented. If a child required a routine dental visit, we had a pediatric care coordinator that schedules the dental visit at the conclusion of the primary care visit. And in the event the child required an immediate intervention, the child and parents were escorted to the dental clinic for a warm handoff and dental triage that day. So they got immediate care. Some of the challenges that we faced, like as in Johnson City, we did have some personnel turnover, and onboarding new personnel and putting them in the new roles was a little bit of a challenge. Also, patients lost to care was our second challenge in phase 1, as I mentioned. And in phase 2, we actually received a grant to hire a dental care coordinator that would work with both of our OB patients as well as the pediatric patients. And it took us a little bit longer to find the perfect person to fit this role. So that did delay the implementation of phase 2 for us, but we did find the right person, and this is going really well. She's coordinating care between the medical and the dental departments, and that has been very valuable to the outcome of our phase 2 project. And I think, initially, I think that the buy-in for this project was very, the buy-in was never a challenge, I guess is what I'm trying to say. The key word is teams. For our project, we did recognize and understand there must be cohesive care teams in place to implement every stage of these new workflows. Integrated processes are created through clearly defined shared responsibilities, and everyone understood this. Creating strategic and meaningful processes and process maps have lessened the challenges for both phase 1 and 2. So I feel like in our scenario, we found that the buy-in became the reward and not the challenge. If anyone's interested in any of our workflows or process maps, if you would like to email me, I'll be happy to share those.
Thanks, Carrie. I appreciate you both sharing your perspectives.
Mhm.
Okay. Well, with that, is there anything else either of you would like to add? What I'll do in this last little bit is I'm gonna kind of just summarize what you all had shared again with some of the challenges that, again, go through. I won't spend too much time since you all did such a lovely job of describing some of the challenges that you all faced, but then spend a little bit of time talking about what we're thinking, what Catalyst has identified in terms of what that means, what we have identified from what you all have showed us from this work in terms of what this means for replication and sustainability as we think about what this looks like in the future, not just for Virginia, but maybe even at a larger scale as well. But before I transition to that part, anything else either of you would like to share?
No, not at this time, but I'll let you know if something pops up.
Okay, feel free to jump in as I'm going to. If there's anything that I'm saying that you would like to clarify, or if I'm misspeaking, let me know, okay?
Will do.
All right. So as you all heard, it was, I think that both Johnson and Crossover really demonstrated that this was not an easy project for them to do, but they, I think, really also demonstrated that um, there is a lot of opportunity here as well. And we really appreciate the engagement that they had throughout these past 2 years with this. They both discussed this work was not met without its own challenges, but there were some opportunities to think about and get a little creative in terms of how we could overcome some of those challenges. And I also understand that some of the solutions are even a little bit beyond what is available in this exact moment, and things that we'd have to think about well beyond what is even available within our own communities, and involve maybe larger, more system level changes as well. Um, as you had heard from both Johnson and from Crossover, making sure that you have buy-in and having teams that are really committed to this work is incredibly important. As you heard from Carrie, just again, having a team that just buys in and is really committed to this work from the get-go really helps lay that foundation. So having some ones at your clinic that are just ready to come in and collaborate. So there's can be awareness regarding oral health's role in chronic disease management. Sometimes not always knowing how to support their dental colleagues can sometimes be a challenge. So thinking about how you're able to find to be able to achieve that true buy-in as well. But what we found is being able to, again, find that common ground and thinking about peer learning sessions and finding that opportunity for mutual understanding across those disciplines. I think one thing that I had enjoyed getting to do with Crossover in particular was getting to do some of those training sessions with their medical teams in terms of uh, talking about how we can better support and make sure that medical teams are feeling a little bit more comfortable with some dental aspects when they're doing like their oral health screenings as well. So finding those common grounds and looking at opportunities to potentially create shared problem lists within the EHR. And again, looking for that interdisciplinary respect and accountability. So I'm always struck by that story that you shared, Dr. Al, where when you first talked with your original medical champion, and she's like, why do you keep sending us patients with hypertension? And just having that really candid conversation, I think really can help just again lay that foundation, and having that chance to come together and have that respect for each of your own disciplines, but understanding where you can share and take responsibility and coordinate with one another to help support the health of your patients as well. As you heard from both of the teams as well, turnover is something that can be a challenge. A lot of it does come back down to needing to retrain then. Unfortunately, this is something that I think will happen in health centers that we do experience. So it does mean that new hires might be unfamiliar with the ICD-10 codes and the purpose of the social determinants of health C codes. And that also means that there are competing demands that happen as well. But that does mean having things like adaptive onboarding and some of those resources available to help catch up new hires onto that work as well can be really useful if it's something that you do choose to integrate into your clinic as well. EHR integration can be a challenge. One thing that I think served both Johnson and Crossover well is you all did have EHR systems, though, that did integrate really well, but that's not necessarily true for every EHR system. Some electronic dental record systems are not going to integrate clearly with electronic medical record systems. I believe Johnson and Crossover, you both use eClinicalWorks. So your medical and your dental records all were able to integrate very easily within your EHR, but that isn't necessarily true across the board. So understanding that, doing some process mapping did help with being able to do some of that system integration as well. So understanding where there's opportunity for the interoperability. However, beyond what is available within your own EHR system, there is definitely a need for wider and broader interoperability solutions too, in terms of what electronic health record systems are capable of doing. And that is something that is beyond the work of your community health centers too. So just something for us all to consider. Resource and service gaps within your health centers. I think many of us can appreciate that your health centers do offer many things, but you can't be all things to all people. So many health centers might not have specialty dental care available on site, or there might be a need for additional social services that aren't available within the health center. Developing things like community partner maps can help identify outside referral source. However, there is still going to be gaps that might exist within your community. You might identify problems in your community, but you still lack a solution, and there's still additional infrastructure resources that aren't available. And that's where that advocacy comes into play, that moves beyond just the work of what is available within your health center, within your community as well. So understanding that gaps still do exist, but this work can help better inform and give some more quantitative, tangible information to help inform those advocacy efforts as well. As captured through your ICD-10 social determinants of health codes. And then this lack of reimbursement, both for your community health center workers, but also the fact that when it comes to ICD-10 coding, especially for dental procedures, and then also ICD-10 Z code coding, it's not tied to any reimbursement mechanisms right now. So there's really not a strong incentive to include this utilization of ICD-10 codes at this time. It's really interesting information to gather, we have learned. However, it's not necessarily financially incentivized to be gathering that information. So it might and often will get deprioritized when thinking about the other work that does need to get done and recorded during an appointment. As we kind of think about what that means, it means kind of considering what that means in terms of how do we be able to advocate for integrating this as a foundation for a more value-based care system and how it can be utilized as parts of population health analytics to help quantify the impact of social needs interventions as well. When it comes to thinking about sustainability and replication of this work as well, I do want to highlight 5 key elements of sustainability. So when it comes to sustainability of this work, having a standardized framework and tools, one of which will be a implementation playbook that Catalyst is working on developing. We are hoping to have that available to share out with you all in the coming weeks, so be on the lookout for that. That implementation playbook will have examples of our readiness assessments, some workflow templates, and some additional guiding and additional guide to provide information on how to roll out and evaluate integrating ICD-10 codes into your own clinics beyond just your medical workflows, but into your dental workflows as well. Workforce development and cross-training, so thinking about building staff capacity across your medical, dental, and social work teams through ongoing training and peer learning. Ensuring that you have interoperable health records through your medical and dental systems that embed these ICD-10 codes into your EHR workflows and establish clear data reporting pathways. Applying your PDSA cycles to monthly data reviews to identify barriers, test solutions, and drive that iterative improvement in your workflow adoption. And engage organizational leaders, state partners, and community stakeholders early to align goals, secure resources, and support that long-term sustainability of this work as well. And then for that sustainability itself, thinking about how we can integrate ICD-10 codes, including our social determinants of health C codes, into Medicaid and value-based care frameworks, and advocating for reimbursement for our community health workers, care coordination, and preventive dental services. Investing in staff retention, cross-training, and leadership development to maintain program continuity despite turnover, and creating succession planning and onboarding plans to preserve institutional knowledge. Strengthening your EHR interoperability between medical and dental systems, maintaining dental dashboards and other data dashboards to track coding trends, referrals, and outcomes, embedding your ICD-10 integration into strategic and operational plans, designating site champions and QI leads to ensure accountability and alignment with the health center goals. And then finally, maintaining collaboration with your primary care organizations, public health agencies, and social service organizations to leverage shared learning and networks to exchange best practices and support policy and advocacy. Really, the take-home message from this work that we've had is that ICD-10 integration is achievable in the dental safety net setting, but it does require coordinated investment. So when policy and your health information technology infrastructure, your workforce and your community partnership align, it is a really powerful tool to for equity and value-based care. This pilot has given us a lot of really valuable insight into the potential for a replicable model and a pathway to help scale this work across community health centers, across states, and across healthcare systems. This is a really great first step into what this means for an opportunity to not just improve the health of our patients, but the health of our communities, and to really think about what a better and a more person-centered collaborative healthcare system could look like for our communities as well. So with that, I would just like to say thank you all for tuning in and joining us. And I just want to say thank you again to Johnson and to Crossover, and especially to Dr. L and to Carrie for really leading this work at their health centers as well, and for engaging in this work. With that, I'm going to stop sharing the slides for a moment and come back on screen so we can do a little Q&A in this last bit of our presentation. Okay. All right, I do see we have one hand up. Vanessa, you have your hand up. Would you like to come off mute?
Yes, hi. Thank you so much for this presentation. This was great. I really kind of resonate with the recurring theme here, which is that you really need a champion to, or a group of champions, I should say, to kind of get these sort of integration projects off the ground. So I really appreciate you guys sharing. I have a few questions. They're fairly short. The first one I wanted to know is specifically for Carrie. You'd mentioned like that you provided an example of two patients who were actually able to receive partial dentures, important for their nutritional care plans, which is great. I was curious to know if there were any like kind of closing the loop here because we talked about ICD, but we also talked about Z codes, and I was wondering if there were any like social determinant of health or Z codes that you looked into specifically for these two patients, given like I think one of them has to do with like food security, if those were changed at all, or if there were any changes to them as a result of them getting dentures.
Thank you, Dr. Marino. So for our project, our clinic has an umbrella of services for our primary care patients, and social determinants of health are something that's generally determined during intake of new patients, and also through, at the time, we did have social work that would follow up with the patients that were identified with, needs. So as part of our particular project, we did not implement the Z codes because that's already taken care of through other departments and followed up, by other professionals in our organization. So that wasn't necessarily part of our dental medical collaborative project. That was already, it's funny because when we identified our patients, those Z codes are already existing in the patient's profile. So that's one of the first things that we do when we screen patients in here.
Got it. I'm just curious to know if, like, now that they've restored their dentition, if their perception on their, I guess maybe like food insecurity is a physical thing, right? We can measure it, but maybe their perception, I don't know if there's any Z codes that might be able to kind of better capture a perception of food stability, but that would be a nice kind of QI project.
Yeah, that
Thank you
would
for
be,
sharing that.
And I'm not sure, McAllister, do you know of any of what some of those Z codes look like?
Yeah, that is such a great question, and I'm going to be looking on my other screen right now. If you have other questions, Dr. Moreno, feel free to ask them while I take a look at the list. But that is such a really excellent question, though, too, because I think perception can play such an important role too in terms of how our health also how it affects our health too, because it's research does tell us that too. The literature also tells our own perceptions can and does impact our health, not just this like our environment, like a known status of our environment. But let me take a look at my Z code list once.
Totally. Thank you. And then the last question I had was, when you were speaking, Carrie, this one's for you as well. When you were talking about phase two, and then you guys received a grant to hire a dental coordinator, I think you said to work with your OB and your pediatric patients.
Yes.
Um, so were there any earlier initiatives before this pilot at improving the referral process? And during that time, if even if there wasn't, were there discussions that ever came up about sharing responsibility for managing referrals, or did you get the sense that other departments viewed it as like outside of their role, which I think can happen a lot when in this like medical dental integration space because we're all very busy, but it really does, take a coordinated effort. So I'm curious to hear this because with limited funding, like what with we're dealing with, this might kind of be a thought, but it also has to get buy-in, even from those non-clinical staff. So I'm curious to know if that was ever a conversation before the pilot.
So, we've been going down our integrated clinic journey for a long time. We started many years ago when we became a patient-centered medical home model. So we developed our integrated in-house referral process a long time ago. So a lot of times what happens is our primary care clinicians, they will make in-house referrals straight to the dental department. Any type of specialty dental referrals that are we cannot manage internally. The dental department manages any of the outside referrals, but everyone, I can't talk enough. I could talk all day about our integrated process with crossover and the communications that takes place via our electronic health record from department to department. But to answer your question, generally the clinicians would make the pediatric dental referrals. They do make the emergent referrals as part of our phase 2 workflow that we implemented. The pediatric care coordinator, she does do the in-house routine dental referrals for both OB and as well as the pediatric. But a lot of times, if it's more of emergent, our workflow indicates that the primary care clinician make those in-house referrals straight to the dental department. If that answers your question at all.
I mean, it seems like you guys have pretty well-rounded, buy-in, which is great. Yeah, that does answer my question. Thank you.
And I did check Dr. Marino. I'm not able to find a specific like perception type code, but this is just me very briefly looking. I'm going to put my email in the chat. If you want to reach out to me, we can definitely continue this conversation later if you would like. And then I know we have time, I think, for one more question. And this one, I think, Carrie, is for you. So you mentioned for your phase 2, we did some training with the primary care, and they had that training on how to evaluate the oral cavity. And the primary care started to put in an ICD-10 code prior to their warm handoff for the dental appointment. What ICD-10 codes were they putting in? Were they putting in Carrie's codes? Were they putting in Superior codes? What ICD-10 codes had we identified for primary care to be utilizing? Which I'm putting you on the spot. I know the answer,
well,
but I'm going to put you on the spot.
I'm very ashamed I don't have my ICD-10
Okay.
cheat sheet right in front of me, but most of them are for caries. A lot of kids do present with multiple caries issues and sometimes abscesses. So most of the K codes that they use to put in an emergent type of referral would be, generally caries or pain.
And we had worked, and after some discussion, we had decided to utilize unspecified caries codes and like accretions on the teeth. So not getting very specific, but talking about identifying if it was, and when we did that training with the primary care, looking at this is what a distinct cavity would look like, or suspicion of a cavity versus what we think plaque would look like, and going through that training process as well, and having that on the cheat sheet, which as Carrie said, we had available for them in their clinics as well. So that way they feel familiar and comfortable with that as they did that for their referrals.
The cheat sheet with descriptors have been really helpful for the clinicians. And I will say that, we just encourage them when they do a visual exam, anything that they see that makes them uncomfortable, even if they don't feel, we just ask them to code it and send the referral. We're not asking them to diagnose the condition, but some of them are pretty obvious, like caries, fistulas, plaque all over the teeth, things like that, inflamed gums, pain. So yeah, we just encourage it, and a lot of times if the ICD-10 code may not be accurate, that's something that we can fix in the dental department. We can go in and update the ICD-10 code to a more appropriate code if necessary.
Thank you. Okay. I know we're a little bit past the hour, so I thank everyone for hanging out with us a little bit longer. Dr. L, Carrie, thank you again for taking the time to share with us your experiences and joining us again. I cannot speak enough to how much your commitment to this work has really provided with us with a lot of insight about not just how important this work is, but a lot of the insights that I think we have gained at Catalyst in terms of what else is needed beyond this work. As I think I've shared with Dr. L, it's more than just having the dentist click another button in the chart. There's a lot more to this than what we've talked about before too. But yeah. Oh, awesome. Thank you. But with that, we'll go ahead. We'll close it out for today. Like I said, we'll have the recording available, so we'll make sure that we can share that out with you all. But thanks for joining us today, and thanks for all the questions. If you have any other questions, please feel free to reach out to us at Catalyst. We'll make sure we'll get you connected with whomever we need to help answer anything else. But thank you everyone for your engagement, and have a wonderful rest of your week.